I'm Dr. Jesse Morse. I am double boarded in family and sports medicine. I'm based predominantly in Miami, although we have 4 offices in the US. I specialize in 2 different areas. My primary area is non-surgical sports medicine, with a focus on regenerative medicine, PRP, and stem cells. And then my second thing I also see and treat a lot of is kind of advanced IVs as it pertains to mitochondrial dysfunction, health optimization. I see a lot of mercury mold patients. I have several patients in the other room right now. I'm in clinic with cancer and weird, complicated things that I'm trying to optimize. You can see when I'm in one of my rooms now, this is an ozone machine, ozone generator right here, doing EBOO. So we have all different variants that are trying to actually help the body as opposed to what I call band-aid medicine. So no temporary stuff, trying to identify the core root problem and try to optimize a combination of peptides and various IVs and stem cells and methylene blue and ivermectin and rapamycin and some of these other beautiful options, tracking different things like clotho genes and whatnot. I speak at a fair amount of conferences. I was just at RadFest in Vegas 3 weeks ago, speaking about anti-aging and joint injuries and whatnot. And I do a fair share of conferences around the country, and I was in Rome in March as well. So talking about kind of a very unique approach to injecting the body, which I'll talk about today in some capacity.
Thanks a lot, doctor. Thanks a lot for that. I think Adebola wanted to ask something first. Oh no, actually, Lauren wanted to ask something first.
Oh yeah, sure. Hey, Dr. Jesse, great to meet you. I'm Lauren. Yeah, I guess, well, yeah, I have a lot of issues with like knee injuries and stuff, and just kind of like a lot of, yeah, like I've tried a million different things. Like I've had hyaluronic acid injections and PRP, and I have like a weird cartilage injury. And I guess like, I mean, I could kind of sustain a conversation around that in general, but like maybe we could kind of start with like, what are you seeing most often happening with knees? And yeah, I mean, like, I guess like what are your like base level tips for like avoiding knee injuries or like managing knee injuries after having them that maybe people wouldn't just think about by default?
Yeah, I think we can definitely discuss that. I think we have a loose agenda, so we can kind of roll that into the knee section. You'll hear a lot of similar things for different body parts. The knees are particularly common, unfortunately. But whatever topic that they all want to start with, we can kind of go from there. But I'll discuss that in the knee section.
I think we can start with that first.
Okay.
That'd be great. Yeah.
So traditionally, most people address a knee issue with a single or double injection. But if you think about the knee, it's very complicated. There's a lot of moving parts. The quad tendon and the patellar tendon basically play tug of war. Most people think they actually walk like this, but in actuality, most of us have a medial tilt. So there's a lot more wear and tear on the medial aspect of our knees, the inner aspect of our knees. And that leads to cartilage injuries, that leads to meniscal tearing, that leads to a lot more stress on the hips, the lateral hips. That leads to, especially in women, this puts a lot more stress on their ACL. And there's a lot of things that have a tendency to have a downstream effect because of this alignment issue. If there's any scar tissue or old injuries, the body only heals to about 85% naturally, so you never get quite back to 100%. So what we've realized is that these scar tissues are less flexible and weaker, so they have a tendency to be the weakest link, and they have a tendency to kind of re-injure over and over again. The body tries to throw down scar tissue, whether it's in patellar tendon or meniscus or wherever, because it doesn't have the ability to build new ligaments and tendons. It doesn't have that luxury. So a lot of the times when I see a patient, whether I do ultrasound on them, which is often, or I get an MRI, or I'm just evaluating by hand, I need to figure out where their issues are. Where's their pain? Where does it correlate? Is it sitting? Is it standing? Is it during a flexion? how stable is the knee? Which areas of the knee are likely contributing? So when traditionally when someone injects, whether it's cortisone or hyaluronic or PRP or whatever, they're usually only injecting one or two spots. The problem is the knee is built in a way that if you only inject the joint, I think of it as a balloon, then 50 to 60% of the injuries are outside of the balloon. That product is not going to magically go find that injury. You need to put it where the problem is. So the approach that we take here in my office, and that it's not super common in America, but it's called the prolotherapy based approach. And that essentially means you want to inject each ligament and tendon at its what we call enthesis, so where it attaches to the bone. That's traditionally where it gets beat up, where it gets torn, and where it gets weak. So if it's the patellar tendon, then you're going to traditionally inject it where it attaches to the patella, where it attaches to the bottom of the kneecap. But ideally under ultrasound, and you're going to look at it and you're going to break up that scar tissue and then refill it in with a PRP line or stem cell line or whatever you're trying to achieve. Now, I have the luxury of pretty much every stem cell available in the United States. The only thing I can't do is modified or manipulated MSCs. And Florida actually just approved stem cells legally, at least to advertise, about a month ago. So we're moving fast, which is nice. The important thing is to understand that cortisone doesn't really fix anything. It tricks your brain into thinking there's no injury. But that injury is telling you, hey, I have pain, there's a problem. So what happens if you negate that pain? You just turned off that receptor and now you're going to push through. So that mild injury is probably going to become moderate because you don't have that reminder, hey, don't be in pain, don't. So ideally you actually address the problem. Good physical therapy goes a long way. Sometimes it's an upper body, it's a downstream thing. It could be hips, it could be lumbar, it could be a myriad of other issues that are kind of messing with the alignment of that knee or the body part. So traditionally, we look at several different areas and say, instead of just doing one little area and inject it and hope everything gets better or perform surgery in that, I literally inject everything. So traditionally, when I do a knee injection, it's between 12 and 15 injections, depending on the specifics, and usually between 1 and 3 rounds, meaning doing that 3 different times, whether it's over the course of a week or a month or depending on the patient's schedule. And traditionally, we get really good results with that. If it's a mild sprain, PRP is sufficient. If it's moderate, okay, maybe you need a little stem cells. Maybe you just need to be a little bit more aggressive with PRP. If it's moderate to severe, okay, now PRP by itself is just not going to be strong enough. To give you a gauge, there's multiple different levels of PRP. And I call them, kind of liken them to cars in America. So you have your low level single spin pit kit, which is probably for hair and face. Those are not super potent, 2 to 3 times baseline platelets. They're going to be pretty benign, not really for the joints. Then you have your most common kits, probably 70, 80, 90% of the kits. They're 3 to 5 times baseline. They don't give a whole lot of volume, maybe 3 to 5 cc's of PRP. Not super potent, but they are double spin. I call these like Mercedes. So they're pretty strong, but they're not super duper strong, and they're pretty prevalent. So your Arthrexes and all these, this is very common for this group. And then there's a very small niche that there's 2 companies, Emsite and Magellan, that have really potent PRP kits. Their baseline platelet 7 to 9 times. They are double spin. You can actually manipulate to get the Buffy code if you want. And then you can actually enhance them with photobiomodulation, with red light and different types of light, and then directly inject them into each ligament and tendon. So depending on what you're trying to achieve will depend on what you need. It's not like a one-stop shop. It's more of a personalized care, at least it is in my opinion. And if the entire knee is pretty good, but you have one area that's beat up, maybe you use PRP and some of the milder areas, and maybe you save a stem cell line for the bad partial tear or meniscal tear or partial ACL tear, or whatever it is. The good, I usually say with a moderate to severe injury, 60% will be either surgery or injections. 40% will be good physical therapy. So when I send someone to physical therapist, I don't want them with 8 other people on a hand bike. That's a waste of their time. I want one-on-one for 30 to 60 minutes. Dry needling, grafting, cupping, blood flow restriction, like manual one-on-one. I want you to break up scar tissue. I want you to reset the biomechanics. I want you to correct the compensation patterns first, then progress to muscle balancing, making sure medial is just as strong as lateral, so on and so forth. Finally, muscle strengthening at the end, and you can finally make true progress with that. It didn't happen overnight. It's probably not going to be fixed overnight, but you can make significant progress if you address each of the small areas of instability, because that allows you to collectively make everything stronger. Most people, when they inject a single area, it's almost like I almost like liken it to like a fire on the top of a mountain. And if you're sitting on the base of the mountain and shooting it up and hoping it hits it, that's kind of what cortisone does. When we use stem cells or PRP or something along those lines, with ideally with ultrasound guidance, I almost think of it as like a helicopter, and you're literally finding the fire, and you're like boom, boom, like you're very specific, very, very direct. So we're not hoping we're getting it, we're actually watching it, whether it's guidance or landmark guided, just depending on the location. And you get a lot better results, but there's certain things we can't fix non-surgically. If someone comes in a full thickness ACL tear, unfortunately, I'm going to send you to get surgery unless you don't want surgery or you're not a high level athlete. Same thing with Achilles. I fixed several Achilles that are not high level athletes, but you're going to cost a lot of money and you're never going to get the same level of explosion back. And that's okay. But you have to understand what you can and can't do. And unfortunately, some things don't have the resources or the experience to be able to do that. But if you have the right diagnosis, if you understand where the injuries are, and you put the right volume of product in the right product or type of product, you can make some really, really cool things fixed. I'm not a big fan of just band-aid medicine where they're kicking the can down the road and waiting for it to worsen, eventually just requiring surgery or replacement or whatever the social norm is. So I think there's a lot of potential, but it's not a generalization. It's very personalized, or at least understanding that red light works great. PEMF, there's the various different things that can be really helpful. It just depends on what the specific issue is, and what you've tried and what hasn't worked.
Thank you so much, doctor. I actually wanted to ask about shoulders, but from a preventative angle. Like I hear a lot of young men, they end up having rotator cuff injuries, dislocating their shoulders in the gym. So what can we actually do to stop that from happening? And what's the main reason that it's so common for everybody who goes to the gym after like they're 30?
So shoulder is by far the most complicated joint, simply because if you think about how many different ranges of motion you have, the knee and the hip are relatively straightforward. They're pretty much in a single plane to an extent. Shoulder, you have crazy range of motion. You can front, back, behind your head, up and around the corner. Like you can do all this stuff. And that, because of that level of movement, it has to have a lot of range of motion, but it also has to have a lot of stability. Now, the shoulder is essentially 2 different joints. You have a ball and socket joint, which is the goniohumeral main joint, and then you have your AC joint, which is basically supportive at the top. The goniohumeral joint is traditionally where people have their issues, and the labrum, which is a big, thick piece of cartilage, is basically surrounding that goniohumeral joint. The problem is it does not heal in anyone. I don't care if you're 20 or 50. I don't care if you're pro or a regular person. It don't matter. It doesn't heal. It has an awful blood supply. It scars down. And what happens over time is it just gets loose. So that body starts to sense, hey, that's not stable. And what can happen is it's almost like a golf ball on a tee. So if you're sitting here and the tee, the labrum is holding it on, is relatively loose, that ball can pop out of that socket. If you happen to trip and try to break your fall, pop it out. If you happen to pick something up or get hit, in American football, when you get hit and that shoulder goes backwards, well, that's going to pop that shoulder out of the socket. In an ideal world, it's going to pop back in, but now that joint is never going to be the same because it doesn't have the same stability as it did before that injury. Rotator cuff It's basically a group of 4 muscles, predominantly 3, in the main part of the shoulder. So there's 2 in the front and there's kind of 1 in the middle to the back. These are responsible for anything out in front, anything overhead, pretty much anything when our arms are extended. When and each of them have their own little role, and they kind of help each other depending on what you're asking to do. Think about it this way. They're almost like car tires, in that you're 50 years old, you've been using the same car tires to move every single motion your entire life. How do those car tires look? They're going to be really beat up. You don't have the luxury of changing out those tires when you're 20. So you have to be smart about lifting. You have to be logical about bringing those arms close to your body, because then you can use back and you can use core. With the people that are lifting heavy, you have to be careful. The farther it out from your body, the more stress it's going to be on that rotator cuff. As you start lifting directly overhead, which is not the most comfortable and safe maneuver, you're going to start stressing that labrum at the bottom, which is not a common injury, but that's pretty much the only way. If you're pushing something up and the stress is going down, the issue with the shoulder is you can't not use it. Everything you do with your hand is unfortunately part of that damn shoulder. So you can't even open a door without extending to reach the door. If not, you're going to have to hit yourself with the door. So you have to use rotator cuff. You have to use that labrum by stabilizing that shoulder just for opening that door. So as that rotator cuff starts to wear and tear, you may have reminders, hey, I don't like that. There's a little bursa, or kind of fluid-filled sac, in between the rotator cuff and the bone up just above it. And the goal of that bursa is to prevent rubbing of that tendon. But what happens is that tendon, the rotator cuff tendon, often gets injured and inflamed and gets fluid around it. So that bursa, which is right above it, and had a tendency to suck up that fluid, and now it creates a lot of compression. So you're trying to push through something, and that rotator cuff is squeezing between a bone, a rotator cuff tendon, a bursa, and another bone, and it just hurts like hell. So you have to be smart in order to make sure you're not lifting super heavy, you're not very vulnerable, because once you start to beat up that rotator cuff tendon, it's very difficult to get it back to perfect again. I've seen 14-year-old baseball players with partial tears of their rotator cuff tendon already. And the part on ultrasound, you can see it actually pull off the bone. There's like a gap in the ultrasound on the bone telling you, hey, that tendon is no longer where it used to be. It's kind of reformulated. And the problem is we use this throughout our whole life. So rather than just Band-Aid medicine where they put a little cortisone in there and it magically feels better, that doesn't really change anything. That just basically allows you to continue to push through that temporary injury and try to figure out how to compensate for it better until you can't. And then it's very difficult to go backwards. The nature of the shoulder is so important, because I almost think of it like a symphony, where every single part of that shoulder has to perfectly be in tune. Because if one thing's out of cue, then everything else goes off with it. All it takes is a partial tear here, and now instead of picking it up and being fine here, maybe that hurts. So maybe you pick it up like this. But over time, it can't do that. So now you start doing it like this. And eventually, those compensations just lead to more and more problems. So in general, be smart with lifting. It's okay to lift, but double body weight, triple body weight, a lot of overhead, CrossFit, a lot of these high volume, high weight activities, great in the short term, but they take a beating on the tendon in the long run. I like to describe a rotator cuff tendon as almost like a boat attached to a dock, where the boat would be the arm, the dock would be the bone, and the rope would be the tendon. Over time, that tendon starts to fray because it's trying to hold that boat on, or trying to do what you're asking with that arm. Over time, that tendon or that rope, say it was 1 inch thick, now it's maybe a ½ an inch thick. And even the ½ an inch that's still attached is super beat up and frayed. The problem is you still need to translate that energy through that rope. So what do? You need to restabilize and re-strengthen that rope as much as you can, whether it's through injections, through therapy, or through surgery, depending on the severity and what you have available to you. And in long story short, most people will be affected by shoulder in some capacity in your life, whether it's a minor stupid thing or something that drives people crazy. Usually when it prevents them from sleeping or sleeping comfortably, it will traditionally have them go in and start to get care. And unfortunately, when it's partially torn, or rotator cuff's partially torn, or labrum's partially torn, uh, the traditional resources are much less. So long story short, they end up either having to deal with it. They end up having physical therapy, which sometimes isn't enough. You can do your stem cells and PRPs, or you have to have repair and or replacement, depending on the specifics of the patient. So it's a frustrating injury. You'd rather prevent it than have to treat it.
Okay, makes sense. So let's say if we scrap shoulder presses, any sort of like shoulder presses, and just do something like lateral raise or face pulls, does that reduce the risk for shoulder dislocation?
Yes, some people are a little, what I call looser, or they have a little bit more play than other people. So they're going to be at high risk regardless. The data shows if you are under 18 and you have a shoulder dislocation, it's almost 100% chance to re-dislocate it at some point in your life, usually sooner. The more it dislocates, the more cartilage damage you'll have, the more instability you'll have, the more issues you'll have, no question. For those people, they really need to address it earlier, and then they do fine. I have a 36-year-old patient of mine that had recurrent dislocations from playing American football. So much so he just continued to play through it. Hey, pop it back in, good, make some cortisone, whatever. He's 38. He had significant arthritis. He had no labrum left, and he had a full shoulder replacement at 38. The problem is shoulder replacement at 38, or at any age for that matter, you can't lift more than 15 pounds overhead. That means you can't pick up your luggage to put it in the overhead compartment at 40. So it becomes very risky, because once things are damaged, you can't go back and pretend like they didn't happen. So that and think about it, the shoulder is not even a weight bearing joint like the knee or the hip. So it's not, the reason why we don't traditionally get arthritis in our shoulders, because we don't walk on our hands. Can you? Yes, but it's not very common. So ideally you want to be proactive. You don't want to be doing, crazy overhead presses. And if you're smart and you're doing, traditional dumbbell press or any chest presses, you want to keep your arms close. You want to use appropriate form, and just be smart, whether you do a little bit lower weight but higher rep, or you do pull downs or something like that, but you want to use good form. You're not jerking, you're not pulling, you're not doing weight crazier than you think to try to build muscle, but in actuality it ends up just causing a problem.
Awesome. Thanks a lot, doctor. That makes a lot of sense. Appreciate it. I think Katya was asking something on the chat. Katya, do you want to read that out, or do you want me to read it out for you?
Yeah, sure. Do you hear me well? I'm concerned that my audio is not that good, but yeah, my question was about hip injuries, and hip injuries prevention. So where does facial release fit into your recovery protocols for that? I've been into facial release lately and been finding it very useful for some of the hip conditions that I've found myself in. So would love to hear your thoughts and your recommendations.
So hips are very frustrating. Hips are very common injuries. The hip and the back go hand in hand really well. There's a couple different hip conditions. The hip is a ball and socket similar to the shoulder, although it doesn't have the same range of motion as the shoulder. It has a labrum just like the shoulder. But traditionally, if you look at the shoulder and liken it to the hip, if you look at the shoulder, look at it as a clock. So you would see noon, 3 kind of towards the front, 6 kind of in the armpit, and 9 o'clock in the back. Well, traditionally, the shoulder, you'll tear from noon to 3, which is an anterior, or we call a slap tear, and then back to the posterior. Now in the hip, you pretty much only tear about 2 o'clock, which is kind of right in the front. That traditionally happens if you're younger with something called FAI, or femoral acetabular impingement. I'll tell you about that in a second. As we get older, the labral tears are more just degenerative and wear and tear, and eventually the ball and socket, the ligaments that hold and the tendons that hold the ball onto the socket start to get loose. So instead of moving as a unit, the ball basically rubs, and the cartilage underneath in the ball starts to wear down. And that's when we start having groin pain and pain with walking and pain with sleeping. That's classically a groin pain, which usually, more often than not, is either a labrum, torn labrum, or osteoarthritis in the hip, or a combination of the two. There's other variants, but those are the most common. So the biggest issue that people struggle with the hip is that all of the external muscles that are responsible for picking up the hip and rotating it are neglected. So when people say, oh, I have hip bursitis, which is kind of on the side of the hip, it's not bursitis. It's not inflammation of the bursa sac. It's usually a partial tear of the glute medius tendon. So you have glute minimus closest to the bone, medius in the middle, maximus buttocks on the outside. Don't worry about the buttocks. The minimus is usually the one that causes all the problems. Why? Because it's responsible for picking up your leg and rotating it. So what happens when that leg is rotated and weak and that tendon can't do that? So over time, it starts to struggle to pick up that leg and rotate it. And then that ball starts to rub, and now you start having issues in the joint because the outside part is weak. So ideally, what you're doing is you do that exercise that everyone hates to do when you sit in that little machine and you push your legs out, or vice versa when you bring your legs in. Each of those are going to strengthen a lot of those lateral components. You can do your clamshells. You can do, side planks where you're kind of bringing your leg up. There's all different variants. You can also do the hip thrusters, which women traditionally like to do when they're laying in. They have that kind of bar underneath and they're bringing their hips up. There's different variants depending on what's going on, but you want to keep that core super strong because that's going to allow you to translate that energy from upper body to lower body and vice versa. If the hip and or back is weak, then you're going to eventually have issues with something. And the groin is very frustrating. The hip is very frustrating because sitting, standing, lifting, walk, like everything you do is with that stupid thing, just like the back. So it's not like, oh, I'm not going to do anything with it. Femoral acetabular impingement, or we call FAI, is an instability issue that usually happens in teenagers and early 20s. And it basically means that the hip muscles on the surrounding aspect are weak. So what happens is the body senses a lot of instability, but because it can't create new ligaments and tendons, it creates new bone because that's the only thing it can do. The problem is the bone's not supposed to be there. So you have two different variants. There's a ball and socket where the neck of the femur should taper. And what happens is it doesn't taper, it gets thick. So whenever it's trying to clear, it starts to tear that cartilage and that labrum. Or you have an extra where there's a ball and socket. What happens is it should clear like this, no problem. But what happens is the body creates new extra bone. So now you're clipping that cartilage every time you bring your leg in. And over time, the more active you are, the more wear and tear you'll have in that joint. And now you have a lot of instability, a lot of cartilage damage, i.e. labral tear, and or a lot of arthritis in the joint, even at 15, 18, 20, 30 years old. Because all of the surrounding hip structures are weak, and that's the only thing the body can do. The issue with a traditional approach to injection or surgery with that is that they basically remove those bones that the body created, but they don't stabilize anything. So what did they just do? They removed the bones that the body was trying to use as stabilization. They don't address any of the weaker tendons. They just remove the problem. So over time, what happens? It comes back because the body still has instability, and it's like, well, I'm just going to do it again. So if you inject the surrounding hip structures, all lateral, over time, you can collectively make everything stronger, and then that bone doesn't bother you anymore because it's not rubbing, because everything is moving, and everything is moving on the correct plane as opposed to kind of clunking and rubbing. So long story short, that would be the approach you would take, just depending on specifically what's going on in there. Dry needling, Graston, any of the fascial releases are torture, but very appropriate. I have a tendency to do those with a longer needle because I can. Most of the therapists are not going to do that because they're not comfortable doing that or whatnot. Scar tissue is very, very common and very, very frustrating. That's the body's way of trying to heal, although it doesn't really do a good job. So if you break up that scar tissue and ideally deliver something in there to create new healthy tissue, i.e. PRP or stem cells, then you can actually prevent that scar tissue from forming, get rid of anything that's in there, and ideally develop new blood flow as much as you can and new tissue as much as you can. So that's essentially the approach that I try to recommend, unfortunately, it's not covered by insurance, and at least in America, so it's considered taboo. But just because it's not covered doesn't mean it doesn't work. And in the long run, you want to get rid of that scar tissue. You want to get rid of any of those things preventing that normalcy. And if you still can't make that progress, then maybe you have to do a little bit deeper with what I call a barbitage. It's almost like a 22 gauge or a pretty big needle, ideally with lidocaine and ultrasound, to kind of break that up to allow the body to start healing. So even with a traditional prolotherapy based approach, you can use classic prolotherapy, which lidocaine and dextrose can actually significantly make progress, assuming the tendon's not partially torn.
Awesome. Thanks a lot, doctor. Thanks a lot. I think Revelation had his hand raised.
True.
Yeah.
So my question is, do you have experience with preventative programs that have proven to be very successful in preventing injuries across different sports? I'm particularly interested in shoulder and knee joints, or perhaps another joint, if that would be a better example for you, seeing your experience. I have a friend, he works in football, European football, and the Nordic hamstring curl, for example, has been very effective to prevent hamstring issues in general.
Mm-hmm.
Is there a specific protocol, a sequence of exercises you can recommend, maybe for in general or certain joints? I know it depends on the sport, of course, but perhaps you might have some general guidelines.
Yeah. In general, I think Nordics are a fantastic preventative agent for hamstrings and other things. Not very common in American football, which is probably why they get a lot of hamstring strains. Whereas opposed to the soccer guys or European football guys that run way, way, way more, and rarely or not as often get them. I think one of the things I always have a tendency to focus on make sure the hips are properly aligned and not rotated, because a lot of the times that will change leg length and change tension on that hamstring. So, ideally if they're the same height, then the tendons are roughly the same length. But if this one is, say, an inch higher, whether the psoas is tight or whatever the reason is, then that hamstring tendon now has to stretch another inch. So it's under more tension and you haven't even done anything yet. So theoretically, it's going to be at higher risk. In terms of a lot of the tricky part about the labrum issues, whether it's shoulder or hip, is that despite good therapy, it's very difficult to get those to retighten, to get those to kind of, propriocept. So a lot of the times you may need some of the more electrical stems, E-stems. They have all the different variants nowadays, the negative currents and whatnot, to see if you can get that tissue to cooperate. For, say, a baseball or elbow, a lot of it is about volume. A lot of it is about velocity. A lot of it is about a movement of that pitch. I like to think of most of these injuries as like a car, and a lot of these professional athletes are like a 2023 with 200,000 miles. Like, there's a lot of volume in a very short period of time, and unfortunately, especially if they're playing year round and all this other stuff, it's very difficult for that tissue to, like, I'm doing the same movement over and over and over again. Can I really be surprised if I'm not healing? And then, chronic inflammation, especially with at least here, our awful American diet, causes a lot of problems. Cold plunges, saunas, red light, all of these different variants. I'm a big fan of Kirktruvit, Epsom salt baths, different things to kind of optimize that tissue, grounding, getting in the sun, making sure your vitamin D levels are appropriate. Each of these things can help be preventative. I tweeted this morning, most of the patients that I see have really low vitamin D levels, 30s, 40s out of 100 in American terms. These people are going to have a heck of a time healing. You should be closer to 60, 70, 80. And if you're in the sun for 30 minutes, you're going to get about 20,000 IUs, but not many people are doing that anymore. So you might have to supplement. And a lot of the times I'm trying to be a combination of reactive as well as proactive. Right? Yes, might have an injury or something, but also trying to prevent progression. And don't be afraid to continue to challenge that tissue, whether it's blood flow restriction or dry needling or Graston or cupping or whatever you need to do. And if it's the injury is a little bit more than you can handle, or just the tissue's not cooperating, it might be time for a surgical or MRI or a consult where you might need to be a little bit more aggressive. But the good PTs can, they're really good at addressing stuff. Sometimes the tissue doesn't want to cooperate. My partner is an osteopath, so a lot of the times he'll do a manipulation and kind of put their tissues back into place, whether it's craniosacral or putting the lumbar and the tailbone back in place and all these different things, because we just get out of alignment a lot of the times. And then there's all these different varying stress levels. That psoas is too tight and everything's rotated and cocked and whatnot. So see if you can get things back to normal, back to alignment. And then address the areas that are still a little bit weak after that.
Lauren has her hand raised. Do you want to go first?
Oh yeah, sure. Yeah, so you were mentioning about, you were mentioning, especially when you were talking about like shoulder injuries, about like basically the tendon getting frayed or like strained over time. Like, what are ways that you can efficiently like strengthen your tendons? I know that like doing injections like PRP or prolotherapy like directly into the tendon, I guess like at the insertion point of the bones, maybe that's what you're saying, is one way, but like also just like, strategically loading the tendons, or it's like, how can we actually, because I don't know, I also feel like there's a lot of this idea that like your tendons don't get stronger or like your cartilage never regrows, but I don't fully believe that. And like, I feel like if you set the right conditions for the body, then there's a lot of opportunity for your body to do magical healing, so I'd be curious to know there.
I agree. I think that logical exercises, proper loading, not too crazy. I'm more of an 8 to 10 rep person, unless you're in maybe a unique bulking phase or you're trying to go heavier and go lower volumes. And then range of motion. I wish I had the time for yoga and Pilates and some of the more lengthening things, activities. The other thing is ideally clean eating, because a lot of the dietary issues are going to lead to poor healing. They're going to lead to chronic inflammation, and that, even sleeping, a massive thing that I'm not the best with. But the data seems to show between 6 to 7 hours seems to be the optimal. For some people, maybe a little bit closer to 8. After that, it becomes counterproductive, or at least for the longevity data does. That's when you're resting. That's when you're rehabbing. That's when your body's trying to heal. So you ideally put it in that optimal environment. If you want to take it a step further, maybe you do some hyperbaric or, BPC or any of the peptides. I'm a big advocate of red light. It's one of my favorite things. I do it multiple times a day. But ideally just staying active, eating clean, and making sure that you're constantly moving or moving as much as you can, because movement is medicine, in my opinion.
Thank you so much. Thank you so much, doctor. I think Adebola had a big question. Do you want to read it out? Adebola?
Yeah, thank you so much, doctor. My first question is the fact that I've noticed, well, in the UK, as an injector myself, we are told that we should avoid giving corticosteroid injections to the hip due to the fact that it's chondrotoxic to the cartilage itself. This is either landmark or ultrasound guided. Hearing you talk about PRPs and stem cells has made me a little bit happier, because right now we are limited to what we can offer the patients besides physiotherapy and a hip replacement. In your experience, would you say this is an option, PRP and stem cells for the hip? And second question is, how do you differentiate between lateral hip pain and deep gluteal pain syndrome? Thank you so much.
So I'll answer the first one, then answer the second one, then answer the first one. So lateral hip, there's a couple different options. It's almost always going to be glute medius, usually part of it. You could have a partial tear at the TFL attachment. You could, if you look at the greater trochanter, the glute med attaches to the posterior aspect of it, but the quad actually attaches to the anterior aspect of it. So it's rarely the quad, but it can be. And sometimes you can have snapping hip syndrome and issues with some of the quad attachments where they attach proximally. Every once in a while, you'll have like a groin strain or a pubic athletic pubalgia, which then causes just a poor movement pattern. Traditionally, when it's a groin issue, it's going to be a joint or it's going to be labrum, and they'll have pain when they're sleeping on that side. They'll have pain with walking. If I really need to confirm it, I'll do a diagnostic lidocaine injection into the joint, and I'll literally inject the joint, and I'll say, how much of your pain went away? If 100% went away, then there's your problem, no questions. If 50% went away, okay, where's the other 50%? And you have to keep going. And that does a great job of temporarily setting that feedback to say, hey, where's the injury? Okay, you didn't fix the problem, but you just confirmed where it is. So then you can either do more therapy on it, try a different type of therapy, maybe inject it with a different form of injection. But now you at least have an idea of exactly where that injury is. That's one of the approaches that I take when it's not super clear. The other approach, so one of the things to understand that we've unfortunately learned over the years, my partner's been doing stem cells since 2015, so a good decade now. For labrums, for partial tears of tendons or ligaments, discs to an extent, pretty much require stem cells. So if we step back and say, what are stem cells? Well, there's two predominant types in the body, MSCs and HSCs. But to step back, instead of thinking, hey, they go in there and build all this brand new stuff, that's not realistically what happens. They're more of the ultimate coordinator, the ultimate traffic cop. Hey, here's an injury, you go there and fix it. Here's what you need. Hey, you go over there, fix it. Here's what you need. So if you're trying to fix a problem, put the potency that you need and put it where you need to do it. Say the body doesn't have to worry about trying to figure out where it's going. Just go to work. If it's a mild injury, use mild product. If it's a moderate injury, mild product's probably not going to move the needle. If it's severe, don't waste your time with the mild stuff. You're going to be disappointed. You're going to spend money and you're not going to get the results you're looking for. In terms of potency, I would say prolotherapy, which is your dextrose lidocaine, is about a 1 or 2 out of 10. PRPs are anywhere from a 3 to a 4, depending on potency and volume. And then your stem cell lines between a 6 and a 10, depending on where you're getting from and the person and the volume and whatnot. If you're trying to address a labral tear, a cartilage injury in the hip or the shoulder for that matter, you need a stem cell line, at least for some of that. If not, you're not going to be happy with the results. You just to go to surgery, you'll have probably better success. If it's just a hip strain, try 1 round of PRP. Maybe you need 2 or 3 rounds, but that's okay. And try it after a couple rounds of therapy afterwards. When I inject, I always inject the same spots on my patients. The question is, what's going to be in the needle? Is it prolo? Is it PRP? Is it stem cells? Or is it a mix of them? So I'm always trying to reinforce the same areas. It just depends on the potency I need and the volume I need, depending on what the injury is. And I use high volumes, and I've had really good luck with that as a result. Most people use 2, 3, 4 cc's of PRP. I'm using 30, 25, usually 2 to 3 times. Unfortunately, that's what it takes to move the needle. The pain is uncomfortable. The swelling, inflammation is very real, but so is surgery and so is scar tissue. And sometimes those post-surgical changes are never the same. You can never go back and undo those changes or prevent some of that arthrofibrosis that develops after that surgery, because a lot of the times the body sees that as scar tissue. It's like, hey, I need to react to that with more scar tissue, and then just creates more problems. So unless I can help it, I try to prevent surgery at all costs.
Appreciate it, doctor.
Thank you.
Okay. Thank you, Adebola, for your question. Lauren also raised her hand, but I want to go first with this because this topic wasn't even covered. And I also personally have a curiosity. Whenever I lift weights, I've noticed that although I'm right-handed, my right hand seems to feel weaker. Like I can lift more, like do more bicep curls with my left hand. And I'm not sure why. And my wrist seems to be tightening up. I did have tennis elbow like 7 years ago once. That's about it. And I do like work with a mouse, not an ergonomic mouse, a lot. And I used to play guitar. So could there be any kind of correlation, and how can I prevent any further escalation of that?
Most wrist issues, unless there's an acute injury, are referred from the elbow. Unfortunately, the elbow is under high tension. You're using it for pretty much everything you're doing with your hands. And over time, for some people, their tendons just can't handle that stress, and they start to inflame. They start to become uncomfortable, especially with lateral epicondylitis, your tennis elbow, which is, kind of classically here. If your wrist is hurting and you start pressing down on some of those lateral tendons and they hurt, that's probably the problem, and it's just referred pain down to your wrist. There can sometimes be nerve issues entrapped, usually under the cubital tunnel. Usually where it comes from, it can be from the neck. It's not very common, but it can happen. More often than not, if you were to identify and address the issues with the lateral epicondyle and sometimes the medial epicondyle, a lot of the distal extremity stuff will go away. Because we're using our hands for phones and tablets and driving and pretty much everything we do, they're always being used, and that tissue is ridiculously stubborn in the elbow. Oh God, really stubborn. So it's very hard to truly make progress, regardless of the potency of the product. It's just very stubborn. So even if you just have to keep going back at it over and over again, to try to continue to try to bring blood flow in, you'll eventually make progress. It's just not, it's not fast, unfortunately.
Thanks a lot. Lauren, do you want to go with your
Yeah.
question?
Yeah, you've mentioned stem cells a number of times. And I mean, there's like quite a mixed bag of like stem cell stuff out there. You can get like adipose tissue stem cells, or from bone marrow. You can get it from your own marrow. You can get it from someone else's marrow. And I've done a lot of like research on this. And I mean, one thing that always seems like a bit sketchy to me is like, getting somebody else's stem cells transmitted to you, especially like if you don't know like their vaccine status or general health conditions. And I know stem cells are not supposed to like transfer over any of those things, but like there's also studies about like mRNA proteins being put into stem cells and then having those stem cells be put into other rats, and then that like translates something through the mRNA proteins. And like, I don't know, all of this stuff sounds spooky to me. I'm curious what stem cells you're doing and like any opinions thereabout.
So there's this could be another hour-long discussion for what it's worth. There's two coming out of you as an adult: adipose, which is the strongest in the body, and bone marrow. Bone marrow, classically taken from the posterior hip, has two different types of stem cells, HSCs and MSCs. Unfortunately, they age as we get older. So as a baby, we have one stem cell for every 10,000 cells in the bone marrow. By the time we're a teenager, it's 1 to 100,000. It's already dropped 90%. By the time you're 50, it's 1 to 2 million cells, barely any. HSCs are there to make blood products. They don't exist. HSCs do not exist in adipose. Adipose are pure MSCs. The purpose of an adipose stem cell is to literally make a fat cell. That's the only goal its entire life. So if you're relatively lean, they've been chilling their whole life. When you take adipose stem cells out, you can clean them, I call it, usually with collagenase or one of those, and that's what we call SPF. That stuff is ridiculously strong. You can do that IV, assuming it's your own. You can do that IV, you can do that into the joint, you can do that pretty much into anywhere. Yes, there is a process of extracting it and either putting it directly back in or cleaning it, which usually requires a couple of weeks, and then you put it back in. Now, bone marrow has crazy volume, but you don't get the same level of potency. The issue with adipose is that you get a lot of potency, but not a lot of volume. So you get 3 cc's, 5 cc's, 10 cc's. So if you're trying to fix a shoulder, a hip, a back, you're not going to have enough. That's at least one round. And there's the procedure, which is usually a little mini lipo. And then you have, for some people, have bruising. The high level athletes, they don't have a whole lot of fat. So you're trying to pull it out like their inner thighs, and it's just kind of torturous. I mean, it's just not fun to do. You can spend 2 hours aspirating a fluid where I can take bone marrow out in 15 minutes and put it back in 15 minutes later. For the people that don't want to take it out of you have the luxury of donor grafts or different donor stem cells. So this area is kind of where the controversy lies. I pretty much have access to everything, at least available in America. My favorite, the one I've had the best luck with, is an actual amniotic tissue from a scheduled donor C-section. So this is a donor C-section. Everything's checked for everything under the sun. Mom's been evaluated, early pregnancy, mid-pregnancy, can't be on any meds. Like everything has to be perfect. Mom and baby deliver. tissue is then, instead of being thrown away, it has to be donated. It can't be sold, and it becomes black market. At that point, it gets checked again for everything under the sun. If the tissue is viable and looks good, they will then separate it into two parts: full sheets, which they use in the OR for like Achilles, and then micronized. And I use the micronized stuff because I can't inject a sheet. These are traditionally identified with, every single one has a label and a marker and a source. Like, everything is super extensive. It's not cheap, as you could probably imagine, because of the details it has to go into, but they're not technically alive because they're not coming out of them and going back into you. And they are super potent. So they're anti-inflammatory, and they're actual tissue. So when you inject them, the body uses it as a scaffolding. So you don't really have to worry about it escaping or going anywhere. The body just uses those growth factors to start working. In terms of, you can take adipose out of someone else. It can be quote unquote cleaned, and then you can do it IV, or you can do it into a tissue. Although it does get pricey, you can do it. And then some people use Wharton's jelly, which is from the umbilical cord. I'm not a big fan of that, predominantly because the umbilical cord really only has about 5% stem cells. I promise you, they're not taking 5%. They're taking a lot more garbage, a lot more fluff. Is it stronger than, say, PRP? Yes, no question. But can it have issues? Yes, very much so, especially if you're doing an IV. You can have endotoxins, you can have issues with cross membrane, you can have what I call memory cells, or issues that can react. So yes, that is very real. That's part of the reasons why I don't like it. It's also a headache. You have to use cryo, and it's not fun. You can, and the cleanest stem cell line, I would say, in my opinion, or at least one of them, is actually the inside of the stem cell, what we call the exosome, which are the growth factors inside of it. These are traditionally taken from placental-based stem cells. So the sourcing I personally use here in Florida is from pre-COVID placental-based stem cells. So I don't have to worry about all the headaches for the past 5 years, because they're optimized and pure, and because each stem cell has millions or billions, probably trillions, depending on what you're measuring, of growth factors in each one. You get a stupid amount of product in a very small amount. So it's very potent. These are liquid, so they traditionally can be done near nerves. They can be done IV. You can do them in the face. You can do them in the hair. You can do them, like, you name it. They work anywhere. The caveat is that they're liquid, so they move. So 80% probably sticks in the area. 20% may go to wherever you want, wherever it goes. We're close. We haven't launched it yet, but we're close. Probably for the next 6 months, you can do an IV of exosomes, and traditionally about 20% will cross the blood-brain barrier. Mesenchymal stem cells don't cross; they're too large. 20% traditionally will cross the blood-brain barrier, but say you wanted 80% or 90%. Short of injecting them directly into the nasal passage, which goes into the nose, or brain, which I do here, you can actually inject them via IV and use a very specific type of ultrasound to call the exosomes to a specific part of the brain. So say I want to go to the amygdala, or I want to go to the one of the areas, Broca's, for a stroke or whatever it is. You can actually call it to that area and have it deliver all those growth factors and start the healing process. So most of the issues in the body or in the brain are actually inflammation, either directly or indirectly. So even if you just did stem cells or exosomes in that capacity, you're going to significantly reduce a lot of that inflammation. Is it enough to fix everything? I don't know, it depends. But you have the ability to use these super potent little guys and basically hand deliver them to the specific injury. And then eventually we'll get to the point where you can do these to the kidneys directly. You can do these into, whatever. You can actually put them pretty much anywhere if you know what you're doing. And as long as they're sterile, they're optimal, they're pure, there's no issues with them, and they're FDA cleared, in my opinion, the risk is relatively low. Whether or not they're controversial is a separate discussion. But in terms of benefits, the sky's the limit. There's a little bit of a controversy in terms of what are they measuring, and that's where the billion versus trillion comes from. So that's why there's some of it. You can technically get exosomes out of your blood, but they're not true exosomes. There's like a variant called a V cell that you can go down a rabbit hole if you want. But in general, I prefer some of the more potent extract version, whether they're placental exosomes or all these different variants. And for personally for my patients, I will actually offer them different things depending on. I usually offer 3 plans, like hey, PRP plus bone marrow, amniotic plus PRP, or pure amniotic by itself, or with exosomes, or with something like that. So I'll give them 3 different options. The needle goes in the same spot. The difference is potency, inflammation, and cost. All 3 will work. A year out, you won't be able to tell which one you did. Getting to that year, we'll be able to tell you, am I miserable for 2 months? Or hey, in 2 weeks, I'm not really super inflamed. I'm not 100% yet. Obviously, the price tag fluctuates because you're depending on where you're getting the source and how much you need.
That's really
Awesome. That was, yeah, that
Oh.
was quite cute. Yeah, Lauren. Doctor, I noticed that it's already past your time slot. Would you have like a few more minutes to spare for us?
I probably have about 2 more minutes, and then I got to go see this patient.
Because we didn't really cover anything about posture or back pain, and one of us, he actually struggles a lot with back pain. As far as I know, he has tried a lot of things, so maybe he can ask a short question.
Oh, I guess me. Doctor. I mean, we don't have much time, but I guess any general comments on posture-related back pain, non-injury casts would be appreciated.
First, most important, sitting is the new smoking. Awful. If you look at there's a go to one of the AI bots, whatever, and put in different pressures of the lumbar spine based on different postures. Sitting has the highest. It's really stressful, even more than squatting, even more than deadlifting, which is bananas, but that's what the data shows. The back is very complicated. Neck, to an extent, has less leeway, so it's more complicated, but the lumbar is way more common. The issue with the lumbar is that there's many different moving parts, and it becomes a combination of instability and pain issues. So when you have a nerve root that's being relatively compressed, it's because all the ligaments around it aren't strong enough, and there's some shifting, which then causes that nerve root to get squeezed, which then translates to sharp stabbing, throbbing, aching, muscle spasming, numbness, tingling, depending on what the nerve is doing. If you can stabilize each of those ligaments and tendons, and there's about 30, then the body can use the ligaments as stability and the bones as structure. What happens is the individual bones, the vertebrae, are basically like Jenga blocks, and each of them have ligaments that run up north to south. But over time, some of those Jenga blocks and those ligaments get weak, so those Jenga blocks start to slide. And now the nerves are trying to accommodate that slide. They're not getting longer. So what happens is the body's like, there's some instability there. So what I'm going to do is I'm going to prevent it from getting worse. I'm going to tighten. You can do dry needling, you can do heat, you can do massage, whatever you want to calm down that spasm. But once that body senses that instability again, it goes back to spasm mode. So you have to stabilize those ligaments and tendons, whether it's good physical therapy, injecting into those individual ligaments and tendons, or whatever. I personally try to avoid surgery in the back at all costs, unless it's life-threatening, because the incidence of surgery in the low back is a 50% failure. 50%. That's ridiculous. If there was any drug that had a 50% fail rate, they would never give it, ever. It would be banned. But that's the nature of it. So the low back is so complicated, and you're always using it. Sitting, standing, rotating, sleeping, driving, everything. You can't not use it. So there's a lot of moving parts. L5 is number 1. L4 is a close second. Find a good osteopath. Have them put your tailbone back in place. I promise you it's out. Make sure your hip is properly aligned, your trunk isn't rotated, and then if you need to, individually address each of those ligaments, ideally with a protocol therapy-based approach. Even if it's just with PRP, your back will thank you, and you really won't worry about it. If you have herniated discs and stuff like that, all right, maybe you need a little bit more love. But in general, if you haven't injured your back, do everything you can to stabilize that core, and your back will thank you when you get older. Back is very, very frustrating. The number 1 cause of disability in America, for good reason.
Thanks a lot. Thanks a lot, doctor, for extending your time slot. So in case anyone from us wants to communicate with you and get something like that, how would they find you? And
So there's
where?
a couple ways. For patient wise, if you want to physically see me, the osteocenter.com, TheOsteo center.com. My primary social media is Twitter, although I'm pretty much everywhere. And then you can reach me at drjessemorse.com. And you can do like small consults and stuff there. But if someone wants like prescriptions and stuff, you kind of have to go through the office because Medicare and all the medications and stuff. Malpractice insurance is kind of a headache. My personal Twitter is at DRJESSEMORSE. That's my primary. And then I get intermittent speaking engagements throughout the year, predominantly most part of the year, but I have another one coming up at the Stem Cell Conference here in Miami in October, AASCP.
Awesome. Thanks a lot. Thanks a lot, doctor. That was really insightful. We really, really appreciate the time and the knowledge. And
My
we'll
pleasure.
do
Nice to meet you all. Let me know if you have any questions. Hopefully that was
Awesome.
helpful, and maybe we can do a follow-up at some point in the future to expand on the progress we've made.